Oh, welcome to the virtual global spine meeting for this week. We've joined by people all over the world. I see people sort of flooding in on the guest list here, and I know that a lot of people were really keen on hearing from Meenu and John, my colleagues. So Dr. Meenu Shunmugam and Dr. John Choi both work in Melbourne, Australia at the moment, but Meenu's originally from Adelaide, so there's a bit of a connection there in terms of training over here. Now, they're in the OR, so they're coming in between their sessions, so we had to be a bit flexible in this. And so I'm also doing a talk today on a brief history and introduction to indirect decompression. And this is in advance of a more robust debate that's coming up. But I'm well aware that not everyone that looks at this meeting knows about all the concepts of indirect decompression and where it sort of came from. And it's going to be hard to get through all that in the debate in 1 hour. There'll be a lot of good evidence-based stuff. So I thought I'd just run through a brief history of that as well. Okay, so we've been online on LinkedIn talking about indirect decompressions, and Dr. David Yam from the US put up this, he's got a little meme generator, and he put this up basically saying that, it gets pretty fiery on there. And I think in our basic training, we're often taught decompressive techniques first. And we like to look at the nerves, and we like to go, okay, they're all free. Visual confirmation of a good release is always nice. And, this training, some people say, well, neurosurgeons like to do this more, but I don't know about that. I mean, in my experience, I reckon that there are a lot of neurosurgeons and orthopedic surgeons who are very much into decompression, right? So, sorry, just trying to get this going. Yeah, Meenu and John have been very generous. They're actually in the middle of an OR list at the moment. So that's why we had to be a bit flexible today with our talk. So I want to hear from these guys because there are absolute masters of endo in Australia. We've got a few leaders, but John's been amongst them now for years, and Meenu's learning from the best. So it's very good to have you guys on board. I'll let you get to it. All right, I'm gonna mute, and we'll let you go for it.
Well, welcome everybody. Thanks for having us here at the Virtual Spine. Mike Selby does obviously a fantastic job hosting these events online and promoting it around the world. And we're privileged to be sharing our experience on indirect and direct decompression methods of surgery. We're going to be covering the direct decompression and the most minimally invasive method of performing that. And we've been doing biportal endoscopic spine surgery since 2020. And it's coming up to about 4 years with about 350 cases of experience. And I'll just touch on basic technique overview and where it's come from and where we're headed. And then Meenu will talk about a couple of cases with tips and tricks and technical pearls that you can take home and hopefully implement it in your practice. So evolution of minimally invasive spine surgery has come a long way. Gone are the days of probably for us at least using microscope to perform decompression techniques. And that could have happened using traditional Lamy retractors down to tubular, which all facilitated minimal damage of the tissue surrounding the surgical site and allows for far better visualization of anatomy. However, the complications still remain the same as open surgery, such as dural tear, muscle damage, denervation, seroma, infection, and so forth. And inadequate decompression were not infrequent in this setting because of difficulty of accessing the spinal anatomy and all the patients that come in different shapes and sizes. And then the advances of endoscopic discectomy has really come in the last 10 years. The Koreans, the Germans, the Japanese have been instrumental in populating this technique, and the biportal technique with the Koreans over the last decade or so has really revolutionized this minimally invasive decompression technique. It allows for excellent visualization with very little instrument movement and little capital acquisition cost for the hospital realizing the endoscopic spinal surgery. For me, the two big things come out of endoscopic surgery is that we really preserve the soft tissue envelope around the spine. and we have very minimal bleeding and far less pain in patients postoperatively, allowing and facilitating early discharge. And in the United States, with surgeons of ambulatory surgical centers, it just makes so much sense to be offering this technique to our spinal patients. And this is echoed by everybody. We just don't see infections. We don't see infections, and we don't see takebacks or seromas or traditional damages that we used to create with any open spinal surgery. We're at a transformation of what I think is happening in the lumbar spine as far as decompressions go. And I consider this endoscopic technique to be, third or fourth generation of how we're performing any lumbar surgery, including endolift, which is a fusion. And we'll go into that, I guess, if there's a discussion time that allows it. There's a lot of confusion about what constitutes endoscopic spinal surgery. Largely, there are two, okay? There's one portal system, and then there's biportal system. Uniportal system requires a very specific instrumentation, and it has two distinct scopes. One is an interlaminar scope and a transforaminal scope. One's longer than the other because of the just sheer length that you need to penetrate to the target anatomy. And as you can tell by the name, the approach is slightly different, but it is considered a single procedure, which is making one portal to do the surgery, which delivers light, camera, water, and a tunnel where you can have the instruments fed in. Biportal, on the other hand, completely removes the working portal out of that scope by creating a secondary portal, but still maintains the endoscope, the light, and the water from one camera portal. So extra portal tends to be somewhere between 4 millimeters to 7 millimeters, depending on what you're doing. 7 millimeters maybe for an endolift, and 3 to 4 millimeters for a working portal on a decompression case. And we can perform bilateral decompression, multi-level decompression, cervical decompression, cervical laminectomy, foraminotomy, and of course the fusions. I think it's provides much more versatile approach to endoscopic spinal surgery. And those of you that are performing uniportal will know that it's a long day if you're doing a 3 or 4 level stenosis case for decompression in the lumbar spine. Even in the master's hands, that's going to be taking a lot of x-rays and a lot of time performing the surgery. Sorry about the background noise, Carrie. Thank you. With the incisions being around 3 to 7 millimeters in length, very little muscle damage and almost no bleeding during the surgery. There are some anesthetic considerations that we need to implement in endoscopic surgery to mitigate any of the cancerous bone bleeding during the drilling and burying of the bone. And also, as far as the water pressure and fluid dynamics is concerned, it is something that you have to manage and learn. Otherwise, biportal has a very attractive learning curve. It is basically traditional spine surgery you do all the time, but just done through an endoscope over a microscope or a loop or a naked eye. The approach is identical, and the surgeries that you do can be implemented immediately, all just under endoscopic technique and visualization. Here's a typical patient with a post-operative wound healing at 1 month, demonstrating a very nice cosmetic result of the wound. I consider a minimally invasive spine surgery sort of transition to something like this, which equates to seeing the global anatomy with satellite view or from a Google Earth type of scenario, to endoscopic surgery being close to more like having a Google streetcar, taking snapshots on the ground and giving you far more detail of what you wish to see. And so if you can bring the illumination and the visual field right to the area of your working space, then you're going to be more precise and less invasive. And you don't have to drop a nuclear bomb to kill somebody here. You can just have a sniper, on the ground level, killing your target. So here is basic fundamentals of biportal endoscopy is that you want to target with triangulating the two portals at the disc space that you're arriving at. Usually it's from the left side for a right-hand surgeon, but I guess for a left-handed surgeon, you can arrive at the right side. Hence the term unilateral, meaning that we only approach the spine from one side, and it's biportal, meaning two portals, one cranial and caudal to the target space. And that triangulation is somewhere between 30 and 40 degrees of angulation to arrive and work comfortably. Usually that incision is somewhere between 3 to 2.5 centimeters apart. And of course, dependent on how deep the tissue is down to the target anatomy. I might pass on to Meenu here, and Meenu will take over the talk. Thank you.
Don't go too far. Hi, good morning, everyone. Couple of cases to present. So the first case, 77-year-old male with a 4-week history of left arm radicular pain and weakness. He also had loss of grip strength with pins and needles. Visual analog score 8 out of 10 with mostly arm pain. And that's what he drew out to have the region of his radicular pain. Past history of rivaroxaban, but otherwise not too bad. This is his pre-op examination. So he's pretty weak. He couldn't really make a full fist. And it's his left side that's the weak side.
Yeah, bring it slow, Karen. Guys, we haven't done the drum yet. Okay, full recovery shadows. Yeah.
Okay. This is his MRI scan that we got, demonstrating a left-sided disc herniation. And that's a parasagittal view.
Shut that door so patients go past.
This is a CT scan demonstrating overall quite a degenerate neck with a vacuum phenomenon. And not really a calcified disc. His facet joints are pretty well preserved.
Thank you.
So what are the options? Mike, what would you offer this patient?
Yeah, so that's a great question, Meenu. Look, I think patient needs surgery. They've got weakness and a corresponding lesion on MRI. I have never been a big fan of posterior foraminotomy done through the sort of mini-open or tubular technique. I know there can be some reasonable results, but I've always seen it as stage surgery. You end up doing something else down the track a bit. Other people differ in that view. I think that at this level, anterior access looked possible on that imaging, didn't look too hard. But I'm either doing an ACDF or TDR here. If the facets are well preserved, I may even do a TDR here and really just clear that disc. So, yeah, not something that everyone would do in this situation, but I think trying to preserve motion with that degenerate neck above is pretty important. So if we can, do that, that's a good thing. But I certainly know that now the world of endo is opening up, that this is a sort of almost a perfect case for an endo. And I think it'll be really good to see what you guys have done with this, because I think this is something I'll be referring on in the future. So I want to see the solution.
Yeah.
Sorry, Meenu, I think you cut out for a bit there. I was saying I would probably.
Sorry, Mike, where did I get up to?
Oh yeah. No, you're up to showing us your case, but you were asking me what my option was, and
What were the options?
and I've ended up coming around to, in my hands, I'd probably do a TDR for this actually, if the facets are good, if go anterior, access looked okay. So, but I was just saying, I think the future of this pathology is very much a potentially endo option first, right? Because I don't think you burn too many bridges for later, and I want to see what you guys have done.
Yeah. So I think classically that's what I would have done as well before I joined John. ACDF or TDR for him. And actually we learned recently from a SMS conference that TDR is not indicated for C7T1. So probably
Well, not
ACDF,
indicated. I've done it quite a few times and I've never had one fail yet. But yeah, it's
but
not.
not
You have to
technically
tell,
indicated.
you have to tell the patient that the implant is not technically
Of-
indicated for that level. Correct. Yeah.
Yeah. So we offered him endoscopic foraminotomy, and like I'm used to doing open foraminotomies, and I know that they struggle with quite intense neck pain for a few days. I'm not a fan of that procedure. So this is how we, this was for this patient, how we position them on a Gillespie frame with the eyes protected, tape the shoulders down so we can do a level check, and we tape the head down to slightly flex it. We raise the head of the table as much as possible to reduce the bleeding and also pressure. And then we mark the levels, and I'll put up some x-rays. So that's another picture taken from a book, the positioning with the head up. So we first get make sure we get a proper AP x-ray, mark the level of the disc. We mark the midline. And then we mark the middle of the lateral mass on both the AP and the lateral. That's another picture taken from a book. And that's how we sort of positioned it, because we get x-rays in to do a level check as well. And that's what kind of looks like with the RF probe and the trocar. When we first get in there, so this is an animated picture on the right-hand side. So this is a different level. We're doing C7T1, but that's a inferior border of C5 lamina, superior border of C6 lamina. That's the flavum, and that's soft over there, and that's facet joint over here. So the first thing we find is a lamina bony landmark, and then we RF ourselves outside, and we find the other bony landmark and find the V spot. And then once we know where we are, then we get a level check, and then we start burring a little bit of bone away. Usually the inferior lamina till we get to the attachment of the flavum, slowly peel it off, and then take off a bit of the facet to free up the nerve and to take the disc out. And I've got a video coming up. That's the burring of the bone. And we use a diamond tip burr to try and reduce bleeding. That's again, not for this patient, but that's the disc over there and the nerve root at the top. And the main aim in a C-spine is not to retract the cord, but to just work around it. This is a video from our patient with a C7T1. So that was a V point there. It's the bottom top. Yep, so the root is down there. That's the cord over there, lateral border of the cord. You can either come on top of the root or under the root. And the foraminotomy goes from pedicle to pedicle. And you want to preserve about 50% of the facet joint. And at all times, just make sure you're not retracting on the cord. Just work around it. Blood pressure management is quite important. We usually maintain a MAP of about 80. And bradycardia also reduces the bleeding.
Hey, Meenu, can I ask a question?
Yep.
When you guys do this, have you CT'd your patients afterwards to see how much of the facet is actually been resected? Because I think a lot of cervical foraminotomies I've seen done even open, through a tube, right? People didn't get as much as they thought they got.
Yeah.
And there's a bit of residual stuff there. And a lot of the time the patients actually feel substantial better for quite some time, and then it builds up again, right? So I'd just be interested if you ever quantify how much bone you have removed. It's almost, this to me seemed to be able to see round the corner and along the root a lot better than maybe through the tubular retractor as well. these are great picks. So yeah, are you seating anyone to check on your decompression, Meenu or John? Or
I don't routinely do a CT scan, but I have done it at the early stages to see
Yeah.
how much actually more medial have gone. The foraminotomy that we do under the endoscope usually is very thorough. Inadequate decompression is actually not a problem here. Is that you actually end up maybe doing a lot more because you're seeing more and you end up doing more. So you must hold yourself back from over decompressing the neural elements. And the local anatomy recognition is the key. So we try and drill out about 25% of the pedicle above and below, if it is for a bony foraminal stenosis. If it is a pure disc, like in this case, you saw the quadrant pediculectomy that was performed to access the shoulder of the root. If it was axilla, then we would obviously target the inferior pedicle and do a pediculectomy of the lower level. And the lateral margin of the decompression is really governed by the pathology, but usually about 50% of the lateral, the Z joint is adequate in exploring the tunnel of the foramen. Going further laterally does risk vertebral artery exposure as you venture out more anteriorly to check your decompression and following the root. So that is a caution there. And we've done cervical laminectomies as well for myelopathy patients, even high as C2-3. And you can get thorough bilateral edge-to-edge core decompression quite satisfactorily. So no, we don't routinely do a CT, but when we have done it, we were actually surprised how much we've done it, and we try to be a lot more conservative with our drilling.
Yeah, no, that's good. I mean, I think it's part of it's more, yes, probably wouldn't do it if the patient's doing clinically well, but when you're looking at the learning curve, I do think it's good to quantify a bit of what you're doing, right, with these type of things. Simon Clark from the UK, who's now in Adelaide, neurosurgeon, he's saying he's done lots of open and didn't find neck pain to be much of a problem, but the bleeding was very painful. And the bleeding seems to be much better with endoscopy, the visualization you've got.
I have to agree, the open foraminotomy, the biggest problem is the bleeding intraoperatively, which puts a lot of people off. And it's because in that video, I don't know if it comes out very well, there are several layers before you get down to dura, which is rich capillaries and venous network that can bleed at a very, very a significant rate. And here, because we can define every layer until we get to the dura, we can muzzle that. And the little hook that you saw is about 1 millimeter hook. So it's very precise in what we're able to coagulate and manage the bleeding before it happens. The surgery itself is very quick as well because cervical spine being much smaller than lumbar spine, there's not a lot of drilling and there's not a lot of soft tissue to contend with. So typically foraminotomy for us takes about half an hour. Laminectomy, cervical laminectomy will take somewhere between 40 and 50 minutes.
Yeah. Meenu, I know you're working with John at the moment. I just wanted to ask you, obviously you're doing lumbar and cervical. How many lumbar do you reckon you need to do to be comfortable moving up to cervical?
Oh, that's a difficult question. I think everyone's quite different in terms of mastering biportal, in terms of if you're ortho or neuro. I think it's ortho training. We did quite a few knee scopes and ACL, so we're a little bit, it's a little bit easier, I think, to pick it up and orientate ourselves and triangulate. I can't answer that question because I wouldn't start with cervical. I will start with lumbar, and I'll also start with interlaminar, just decompressions, discectomies before I go to a transforaminal for the far laterals. Only because it's sort of technically a bit easier and safer and less chance of me injuring the nerve root. So I'll start with the simple ones. I'll probably do at least 20 before going to transforaminal, and I don't know when I'll come and observe more and before venturing to the cervical spine.
So I mean, I personally started with transforaminal. I've never done it interlaminar. I've just done a handful, and the transforaminal with the uniportal stuff is it gives a pretty good picture, I have to say. You know, I mean, even when you're doing a Wiltse approach for a far lateral discectomy as a fellow or junior consultant, you know, that's actually quite a hard operation to get right if you're not used to it. And I think the visualization with the endoscope for me in the handful of cases has been fantastic. But I hand most of them on to the local expert for that now. But yeah, hoping Meenu comes back to be our second local expert. So that'd be great. So John, I want to ask you, you know, obviously you're very experienced with this. Do you see a role for navigation in the more difficult cases, you know, where there's really significant bony overgrowth, those very tight stenosis with locked C-shaped facets? You know, those look like really tough endo cases to do to me. Do you see a role for navigation in those kind of cases?
There are papers coming out on navigation UB surgeries, and I think it's going to provide a lot of utility. I think in the setting of degen, as you mentioned, maybe, but I think it has more utility in tumor surgery as well. So tumor separation surgery, tumor biopsies endoscopically, and getting margins right with the resection surgeries and so forth. So navigation is gonna be the next frontier of biportal endoscopic surgery. And then following that will be the robotic surgery infused with endoscopic to lessen the learning curve and for mass adoption of this technique.
Excellent.
And going back to that learning curve question, there's no mandate, I think, on when someone is ready for cervical or when someone is ready for fusion from conventional decompression of endoscopic technique. But I would caution going to cervical spine until maybe they're completely familiar and comfortable with lumbar in all aspects, because you have a lot more at risk with cervical spine, although it's easier potentially because there's less drilling and less tissue to deal with in surgery, but the risks are higher. Cord and the nerve roots are a lot more sensitive. And bleeding can be profuse if you don't get it right. And everybody that's operating has to be pretty familiar with endoscopic surgery before going to cervical spine. The other thing is I always do a lateral X-ray intraoperatively to check in a cervical spine, whereas in lumbar spine, I don't. I'm pretty happy with preoperative check, meaning that you can easily do a wrong level, or you can end up doing multi-levels in cervical spine through a single portal because they're so close together. So when you're doing cervical spine, I urge intraoperative X-ray to check your level.
Yeah, I think that's a good tip, and I think it can happen even with open, right? But you know, using II and endo is a good idea just to make sure that you're all right. Hey, I was going to ask you, John. You know, with doing these cervical cases, right? Are most patients still able to go home technically the same day? In Australia, they probably don't because of reimbursement. But you reckon they're same day cases?
The patients all want to go home within hours of surgery. In fact, last week or week before, we had was it a permanectomy? Yeah, permanectomy patient that went home within 4 to 6 hours of surgery.
That's fantastic.
So they have very little in the way of any pain. I think Meenu's going to show a video of post-operative examination.
Okay, excellent.
So this was our patient who was almost 80. And this is day one post-op. He's in the morning, 8 o'clock in the morning, sitting in a chair. Pretty comfortable. Doesn't really have any neck pain. His power had improved. It's not back to normal, but just improved. Pain was gone. And you can see him, he's going to move his neck in a short while and show us how well he can do that. Yeah. And he went home day one post-op that morning. So I would say less than 24 hours post-op, he left the hospital.
Yeah.
I feel like I'm converted.
No, that's an excellent result. Let's have a look at the next case.
Cool. So second case, 78-year-old lady who's pretty active. She plays table tennis. She had about a 1-year history of right L5 radicular pain, which was constant. And by the end of the day, it's almost like it got a bit weak. She ended up having to drag her leg. She also had paresthesia and a tingling, which was worsening. She was slightly weak, and her leg pain was worse than her back pain. She wanted as small a procedure as possible. This is her a scale of where it was pretty sore on her leg. This is the CT scan. So she had a slight scoliosis, but mainly foraminal narrowing. And this is an MRI scan demonstrating a right-sided foraminal disc. Disc height otherwise overall quite preserved. So mainly foraminal stenosis at L4-5 and L5-S1. So Mike, what would you offer this patient?
Meenu, you know me, it's likely to be, T9 to the pelvis, but I think, no, this is a great case, right? Because I've gone back and forth with our local endoscopic expert about these cases a fair bit, about what you do in the presence of deformity and this kind of foraminal stenosis. And I have to say, as you know, this is a pretty conservative center here where we are. And I would used to try to decompress these patients from inside to out, and they'd often do all right for a year or two, and then they'd come back, right? So that's with a traditional open. And then you're also got all that scar, and you're kind of, maybe burning some bridges for later when you do that. And then I've seen people doing this pedicle reduction surgery. And again, the challenge with, a kind of open pedicle reduction here is that it can work, but again, you're taking away some bony fixation points for later on. And if you don't get it right, you're sort of encouraging some collapse across that segment. So look, I think if you can get access here, endo is a great option to try to treat the leg pain. Again, you're not burning any bridges. Another thing I've done for these patients with deformity is say, okay, we're going to start out by doing just a double level standalone ALIF, no screws at the back, get a good decompression, use good fixation, and see how you go. And if we have to come back and do the back later, so be it. So a few different ways to approach this one, but I've put this case is not probably a little worse than this up for potentially endosurgery before, and I've got mixed answers. So I'll be really interested to see what you guys do.
Yeah, I think this was debatable as well because of the deformity. My traditional old me would have done an open procedure, TLIF from the right side, 2 levels, free the nerve root up. That's the only way I thought it was possible. And then slightly newer me, indirect decompression, probably OLIF and like ATP. I don't think I'm skilled to do lateral ALIFs yet, but ALIF and ATP with some screws. But she really wanted a small procedure. So we did an endoscopic, we had a chat with her and we said, it could recur. She really wanted the smaller procedure, mainly leg pain, back pain, not too bad. So we did endoscopic decompression, and it worked pretty well. And the trick for this one is we came contralaterally. So we came from the opposite side, so we could see right across into the foramen, take the disc out and really free up the nerve root and take off the SAP that would be really hypertrophied and impinging on the nerve root. And her leg pain got better. So I think that was the trick with this one. It's really hard to see back on yourself. So we came from the opposite side, like doing a full decompression, and you can see the nerve root traversing and going out. So it's like 2-level decompression contralaterally.
That's super interesting, because I think using the UBE technique, you can get across and do that right, whereas your uniportal people are looking from the outside and going, that's a tough angle, to get through the foramen and decompress that, right?
Yeah. So I think UBE is good. And then just a little bit about positioning. We use a Wilson frame. We slightly head up to get the back flat. We mark out the midline, the level of the disc, which is the most important. And we put a needle in at the level of the lamina, just as it falls into the flavor. And then John doesn't get a level check once we prep. So we prep with the needle in the patient. So we prep the needle, drape over it, and then we dock our camera. So we dock the camera on the superior lamina, and then we start taking it off. And you can see there's not a lot of bleeding. I think the diamond burr really helps with that. And then we take it off to the attachment of the flavum. We use a little probe to peel the flavum off. And that's the lateral border of the dura. We retract that medially, and that's not this patient specifically. So that's not for the contralateral. The contralateral is a little bit more confusing. So the first steps are the same. We go under the spinous process, osteotomize that, and go to the other side and see right through to the exiting nerve root. So a little bit more technical. Pearls and pitfalls. With a full decompression, things that can happen now with the fluid being pumped in, the dura and the midline forms a sort of a fold, which is very easily picked up by the kerrison and the pituitary. So just to be aware of that by grabbing and pulling, not necessarily cutting with the kerrison. Otherwise, we'll get quite easily get a dural tear. Left-sided approach is usually easier for a right-handed surgeon. So we hold the camera in our left hand for the viewing portal, and the working is the right dominant hand. And in the right side, it's the same, but so always camera on the left hand, but just place our portal slightly different. Blood pressure management, you have to get a good anesthetist. Most patients have an outline to accurately measure the blood pressure through the procedure and keep the map down all bradycardia. Dural tears are a complication. I've not seen one in my time with John so far, but he has had some in the past, just in his early learning curve. And he says if it's more than 4 millimeters, he does repair it. If not, he does not. And he puts a Duragen patch on the inside. I've got a bit of a video here. So that's the dural tear over there, and you'll see the little nerve rootlets quite clearly in there. Great view. And what he's done is he's put a little Duragen inside, and he's using the clips to trampoline that up. And that's it, just as that. And he said the patients are fine. And the other worry is I was asked, talking to John about this the other day, how easy is it to visualize a dural tear? Because I've not seen one endoscopically. He said it's quite easy because as soon as the water starts going in, so you'll be able to identify it on the spot most of the time.
That's really cool. Hey, what are the limits, Meenu? Do you know early in your sort of training, right, with endo, in terms of fluid pressure and time, like, is there a cutoff that you'd say, if you're doing this and you're struggling on your first few cases, how long should you be pumping fluid into these spaces for? Do you know what I mean?
So we don't use a mechanical pump. We use the assistant to pump. In terms of a pressure, because it's a mechanical pump, we're looking at the venting. So we're constantly making sure that fluid is going in through the camera portal and out through your working portal. And that way, if the assistant says, oh, it's getting a bit hard to pump, we look down, make maybe a bigger fascial cut. I think when I've started to do this, like put the ports in, my fascial cuts have not been big enough to vent the fluid. So that's a learning curve for me. And in terms of time, John says there's no real actually time in terms of how long you take to do it before you'll be able to go open. I would probably set myself a time limit. But I think if the blood pressure is maintained well and you're not getting too much of bleeding and you're managing all of that properly, and you're venting your fluid, then you can safely keep going. I don't have a time limit.
No. That's good. I mean, it's something
Take as
that
long as you like. Take as long as you like, because You will be slow when you're learning, and don't need to rush in the lumbar spine. And because the fluid is in and out, and as long as your inflow and outflow is very good, there shouldn't be any problem with anything in biportal. Uniportal, I think there's a bit of a problem, but yeah, because things start to swell up.
All right, Meenu, John, I got a question from Simon Clark again, just saying, what do you think the favorable anatomy is for a good outcome from UBE? You know, should we be starting with high disc height, relatively soft discs if you're going after those, versus the bony compression at the back? You know, what
So
are the
my recommendation is none of that matters. What
Okay.
pathology matter? Pathology. So, first you should be doing ipsilateral laminotomy, and then you should be doing discectomy cases, and then you should be doing full stenosis cases, unilateral bilateral decompression cases, ULBD cases, and then you venture out to multi-level, and then you do fusions. And as far as transforaminal or interlaminar decompressions, it doesn't really matter. In fact, transforaminal is far easier. Just you have to be familiar with anatomy. And it's much faster procedure than an interlaminar for the reasons of less drilling that's involved. Cervical, I would say, yeah, like I said before, be totally comfortable with everything that you're doing, then go to cervical and thoracic.
Excellent. All right, you guys got a case starting now?
Yeah, sorry, our patient's asleep, so we should probably go.
Excellent, excellent. No, I got my talk ready to go. Thank you so much for joining us.
Thanks.
We'll have to get you guys
Thanks,
back to
Mike.
discuss this more, and really appreciate you coming on Virtual Spine today. So yeah, if there's any other questions, fire away in the chat, and thank you for joining us. But I'm going to give a very quick talk now on the indirect decompression introduction. Thanks, Meenu. Thanks, John.
Hey, Mike.
Appreciate it. All right. In anticipation of, we got a debate coming up probably in April now. We're just trying to get everyone that wanted to be involved on it, on a controversial topic we've been talking about on LinkedIn a fair bit. So direct versus indirect decompression. And in particular, you know, there are a few inflamed passions about it in various posts on LinkedIn, and very experienced surgeons kind of arguing with each other about it, which I think is good to see. And I think, though, not everyone is familiar with the concept, particularly people that haven't done a lot of it, or are residents, fellows just starting out. So look, I'm going to just talk a little bit on it now and a bit of the history. This is not the debate. The debate is coming up, but this is almost like a precursor to it, just to set the context a bit. And so David Yam, during one of these light arguments on LinkedIn, has made this meme up, which I think is quite funny. But anyway, that's because I got teenage kids, right? So he's popped this up there, and I like to think that maybe I'm the green cat there. Anyway, so there's. Just going to resume this. Don't know why. Sorry, my screen sharing is pausing. Just going to stop the share. Try again. I might have to run this on a smaller platform. Technical difficulties. Let me just hold one sec. All right, I might have to run this within the application, sorry, but if you can see the slides there, this is a Dr. Leon Wiltse, and if you look at Wiltse, a very famous figure in the history of spine surgery, multiple papers about spondylolysis and spondylolisthesis going from the 60s, 70s, 80s, even into the 90s, and very famous from a number of perspectives because he's described a classification for spondylolisthesis, which I think most of us would know. He's described an approach, a surgical approach to deal with spondylolisthesis, which is the Wiltse plane, which, if you don't know it, is something we use for minimally invasive surgery all the time. And he's also described surgery for the condition. And this is the Wiltse plane. So this is the plane where we're running basically through the gap between the multifidus, which is medial on the spinous process, and the longissimus, which is the lateral part of the sacrospinalis muscle complex. And it's actually a very definable plane, particularly in the upper lumbar spine. As you get down to L5-S1, there are a few crossing fibers and blood vessels, but it's a pretty easily identified plane, usually on average 2 to 2.5 fingers breadths off the midline. Remember, it's the patient's fingers, not your fingers, right? So it does vary depending on the size of the individual. Now, Wiltse has also described surgery for isthmic spondylolisthesis. And for those that aren't aware, it's a classic technique. So this is where this patient here has had an L5-S1 non-instrumented fusion for isthmic spondylolisthesis. Now, the reason they've had that scan is they've come back 20 plus years later with symptoms, but you can see on this video running through on the CT scan, the absolutely solid column of bone between the sacral alar and the transverse process. All right, so what I've also highlighted here is the shape of the foramen, and you can see the L5 foramen is still relatively stenosed in inverted commas compared to the one above. And there is a bit of degenerative change with the superior articular process on the one above, but nothing too bad. And you can just look at that foraminal shape and appreciate that it's about the same size as the nerve root, which is there. And then looking here, you can just see from the coronal image that really solid column of bone going from the alar over to the transverse process. So again, here's another patient that's had a similar procedure done. And you can see here, I'm just going to run the video again. This is an MRI, different patient running through a posterolateral non-instrumented fusion, solid column of bone. This patient, again, has some disease above. They've developed 20 to 30 years down the track. You can see on the CT up here, the solid bone. And here on the MRI, you can see the foramen are very, very clear. Now, with this technique, and if I run back here, I'm just going to run the video again and talk to this. So this patient has spinous process that's intact. Just see here, and intact, right? So they have not had a midline laminectomy. They have not had a gill type decompression where you take it off. They have had an in situ fusion done bilaterally. So a bilateral Wiltse exposure through the fascia, sometimes done all through a midline, sometimes through 2 incisions. They've had iliac crest bone graft taken, and it's been laid down over the sacral alar, over the pars defect after decortication, and over the L5 transverse process. And this patient has gone on to solidly fuse, no implants. They were kept in a brace afterwards for about 3 months. And in the old days, some patients were even casted with this. So, you know, it seems really old school compared to what we do now, but this technique was successful in the vast majority of patients. In fact, Wiltse in some papers claimed complete 100% success, which we probably know is not the case, but nonetheless is a highly successful operation for the time. And if you look at the top 100 publications on spondylolisthesis, there's a lot of Wiltse there. Wiltse, really throughout the list. In addition, of course, Larry Lenke, Keith Bridwell, and Randy Betts, a few famous names on there, have published on this. And they looked at 56 patients with long-term follow-up, and they had 80% clinical success. So not 100%, but still very, very good clinical success. But they found that only 50% of their patients using exactly the same technique had definitively fused. So that's a very interesting kind of outcome. So patients are getting resolution of their L5 radicular symptoms in isthmic spondylolisthesis from non-instrumented posterolateral fusion without reduction. And why do they get that? I mean, technically, the nerves are still compressed. Well, part of it is because of Wolff's law. So Wolff's law basically says every change in the form and function of bone, or the function alone, is followed by definite changes in the internal architecture and secondary alteration in the external, so the outer aspect, conformation, in accordance with mathematical laws. So what does this mean? It means that bone is remodeling according to the stress it is placed under. Interacting with this, I think, is perhaps not as well defined in the literature, is CSF fluid pressure and the role of the continuous pulsation of the CSF. And so when you look back to this patient here, they've got a solid fusion. That's the first thing that's occurred. The fusion's become solid. And then the CSF, and then even the bit that creeps around the root pulsates and it remodels. So you can guarantee that this patient probably had some bone spur formation off the back here before their fusion. Now that's all gone. So we see that remodeling with CSF pulsation. And I think indirect decompression, this is the first indirect decompression. It's the non-instrumented posterolateral fusion, and everything we do now in that space has been built off that. And so that concept has been extended to central stenosis and foraminal stenosis. And when you look here, this is from a paper early days using lateral lumbar interbody fusion for indirect decompression. And you can see almost immediate pre and post-op differences because of reduction of the disc bulge, reduction of the redundancy of the ligamentum flavum and facet capsule at the back of the spine, improving everything. Again, another article showing an interbody cage and showing the way indirect decompression works. Of course, this is a stylized diagram, right? And some MRIs, and it doesn't always work like this. And so there will be failures of this technique. And I think part of this is that you get that initial effect of the indirect decompression opening things up. But if you do not obtain a solid arthrodesis, then it will recur, because the micromotion, if it's not solid, will mean that those bone spurs persist or come back. And that's where you can run into a bit of trouble with this. So I'm just going to show a quick case. So this is a patient of mine. He's got a degen spondy and a degen scoliosis. So he's got a combo of a disease. He's got a kind of transitional level at what I call S1-2 there. And he's got a little bit of sagittal malalignment, not gross, and multi-level spinal stenosis. So we talked through the options with him. He was really very severely disabled by this. And you can see the nerve root redundancy. He's got all the symptoms of claudication, radiculopathy, and back pain. And look, I felt he needed a fusion. Now, in many people's hands, they would agree with that, and they would go posterior, multi-level TLIF, midline decompression, see the lateral recess, see the roots across 4 levels here. And that's a lot of blood loss. That's a big operation. You're taking away a fair bit of bone to do that. And you really need to make sure your fusion is solid if you are going to adopt that approach. My experience with indirect decompression has been so good. I've extended it to more tricky cases like this. And this is just an example of that. So that was his pre-op parameters. This is his post-op at 12 months. Obviously substantially clinically improved. That's a CT scan detailing the surgical plan. So you had a 2-level ALIF, stage 1. And basically when I do an ALIF now, I remove the PLL almost every time. So that at least gets rid of the disc bulge at the front. It allows you, I think, to restore better lordosis. And then he's been taken back for a 2nd stage procedure where I've done a 2-level prone lateral lumbar interbody fusion at what we're going to call the 2, 3, and 3, 4 here, and then percutaneous screws going down to the pelvis. So I have not touched the back of his spine except to drill the back of the facets to help with arthrodesis, just around those screws. So he has had no formal open decompression. You can see clinically, his claudicant radicular symptoms have entirely resolved. And what is that down to? It's down to remodeling. So he's part of a long-term study. And you can see here the pre-op versus post-op MRI at a year. And I think there is still some remodeling to be done here. So, I'm going to be moderating this debate. I do have a slight bias towards indirect decompression, as you can probably see now from a few years of doing this. But I just wanted to introduce everyone to and not take up too much time from the upcoming next session that I host for Virtual Spine. So thank you for listening, and happy to take any questions. Good. All right. Well, we're about 3 minutes away from the hour. If no one's got any questions for me on this, then oh, thanks, Simon says excellent work. Well, thank you, Simon. I don't know if I've converted him to indirect decompression entirely. And I think we'll save for the debate discussions about patient selection and when and how it can work. But I'll be advertising that again in a few weeks' time. I'd love to thank Amna as well, who works tirelessly in the background to make these meetings run. Thank you, Amna. I'm sorry about the technical difficulties I've had today with my screen sharing and it not working on the big screen. But thank you for listening. And I'd like to thank John and Meenu for their contribution earlier. I think hearing regularly about endoscopy is very valuable for all of us. So next week, we'll advertise what's happening online and hopefully see you all then. Oh, yeah, thanks. Daniel's on chat. Great presentations. Thank you, Daniel. As always, thank you for joining us. We really appreciate it. See everyone next week. Thank you.